Welcome to another EduMed video, and in this video we'll be talking about the H-phenotype of COVID-19. We'll be talking a little bit about what oxygenation depends upon, recruitment strategies and the ventilation strategy for patients with COVID-19, especially the H-phenotype. So before you watch these videos, I'd really recommend you go through my videos on the basics of ventilation, where we talk about oxygenation in a lot more detail, and also my talk on why patients with COVID-19 are hypoxic. Suffice to say, the most important thing to bear in mind when managing any patient with hypoxia is to think about this picture here. And what you're seeing here in this picture is the alveolus and the capillary, and that is all that matters in the lungs when thinking about oxygenation and ventilation, i.e. CO2 removal. If the alveolus is full of gas that has got a lot of oxygen and is low in CO2, and it's got a blood supply washing deoxygenated blood around it so that it allows it to be oxygenated, then as long as you've got those conditions, you are going to get oxygenation and you're going to get CO2 removal. Now, in COVID, there seems to be two quite different phenotypes that patients have. That's not to say that one patient will get one type of phenotype and the other gets the other. Often we see a spectrum and patients progressing from one to the other. However, it's worth working out what these two separate phenotypes are because the management of these patients is very different. The H phenotype we can see very early on in disease. So, contrary to the early reports where we were seeing lots of L-type and not many people getting the H-type, we do get some patients who very suddenly develop a diffuse infiltrative picture on their lungs and consolidation that responds very much in the H-type of the COVID disease. However, it's also worth noting that even though some patients may start off as an L-type, they can progress through to an H-type. Now, if you don't know what the L-type is, before you watch this video, I'd suggest you go back and watch my video on the L-phenotype. Essentially, what H-type, or the high type of COVID, is there's a lot of pulmonary infiltrate, there's pulmonary edema, and this is very akin to what we in intensive care commonly treat as ARDS. Now, I'll go through in later videos about why COVID probably isn't the same as ARDS, but for the purposes of conceptualizing this particular phenotype, think of it as ARDS-like. And this is the typical chest x-ray. You get pulmonary infiltrates, you get lots of alveolar collapse, lots of alveolar edema, and lots of increased extravascular lung water. The best way to conceptualize the H-type of COVID is to have a look at this picture. Now, if you remember from the L-type video, we were talking about it affecting the pulmonary vasculature. Well, H-type is much more to do with the alveolar side of this diagram. And you have three main pathologies. One is you get vascular and alveolar wall inflammation. So instead of these two being just 2 cells thick, you now got a lot of inflammatory mediators around there, a lot of thickening and edema, which means that the oxygen diffusion from the alveolus into the blood is that much more impaired. And this is the sort of classical thing that we see in patients with things like pneumonias. So in addition to having that alveolar to vascular interface being enlarged and therefore decreased oxygen perfusion through, you're also getting a lot of sputum plugging, and we're seeing a lot of casts, lots of sputum, lots of exudative secretions that are there, and if they're plugging off the alveoli, you're going to cause alveolar collapse. And also these alveoli themselves are filling up with inflammatory exudate, very much like you would do with a bacterial infection or with a typical patient with an influenza type virus. So these are the main problems. So you can see this is mainly affecting the alveolus. So the treatment strategies that we need to employ to manage patients with H-type COVID are actually to do with trying to improve alveolar recruitment, removing the secretions from the alveolar and bronchial tree, and trying to reduce the amount of edema between the alveolar wall and the vascular endothelium, and therefore improving oxygen diffusion from inside the alveolus into the blood supply. So the H-type stands for the high type of COVID. And again, Gattinoni really talked about this when talking about 4 different parts. And if you've seen the video on the L-type phenotype of COVID, you'll see that there's 4 similar aspects. But in this case, you have high elastance. What this means is that the lungs are full of lots of secretions, lots of edema, and so they're very non-compliant. The compliance of these lungs are low, they're stiff, they're thick, they're full of secretions and edema. But because of that, a lot of the alveoli have collapsed down. So if you can recruit them up, i.e. open them up again, then you can improve oxygenation. And so these patients tend to have a high level of recruitability, i.e. lots of collapsed alveoli which you can open up. And therefore, they respond to high positive end expiratory pressures, or PEEPs. So these patients, unlike the L-type, you can start using slightly higher PEEPs that you would do as with the classical ARDS patients. And what you're trying to reduce is the big right to left shunt. So what's happening in these patients is that you've got lots of collapsed alveoli, so lots of blood is just flowing through the lung but not seeing any open alveoli that will allow oxygen to diffuse into the blood supply. And so you're shunting lots of blood from the right side, it remains deoxygenated, goes through the lung, deoxygenated, and into the heart. But also, you're shunting blood through extraneous blood vessels that are not going through the lung at all. And the problem with this is that you're not oxygenating any of the blood, so you're getting lots of deoxygenated blood in the left side of the heart. By trying to reduce the amount of collapse in the lungs, you can improve the blood flow through the lungs, and you can also use certain things like positioning the patient, like proning them, to improve blood flow through the lungs and therefore increase oxygenation of that blood. But primarily, the problem with H-type is that the patient's alveoli are collapsed, full of lots of inflammatory mediators, or the respiratory epithelial surface is just edematous, and therefore you've got inefficient oxygenation of the blood that's flowing through it. So in terms of the treatment principles, you can see that high PEEPs are probably a good thing. You're going to open up those alveoli that are collapsed because of the low elastance that the lungs have, the high elastance that the lungs have, the low compliance. You can use things called recruitment maneuvers. This is where you slowly increase up the PEEP to a point where you can open up lots of alveoli. Now we'll talk about recruitment and the ways in which to do that. Some people do incremental recruitment, some people go straight up to a high pressure. We'll talk a little bit more about that later. Now, another way of doing the recruitment and maintaining a recruitment and stopping the shear stresses in the alveoli is using an advanced mode of ventilation called APRV. Now, if you're interested in APRV, I've done a whole series of lectures on this as a beginner's guide, so it's worth checking those out. Now, unlike the L-phenotype, where we wanted patients to be euvolemic, when it comes to the H-phenotype, it's probably better to keep these patients on the drier side. This is because there's a lot of inflammatory exudate into the lungs and a lot of pulmonary edema, and we want to try and get rid of that as quickly and as safely as possible. Now, the honest truth is we don't know how much fluid these patients should get. We don't know how dry they should be kept, but probably drier side than the L-type is a reasonable management strategy for these patients. We want to maintain lung protection for these patients. Certainly we've seen in the ARDS group of patients that we, on the ventilator, can cause as much damage as a disease can. And so keeping driving pressures below 15 centimetres of water is reasonable for these patients. Again, if you're interested in driving pressures, please check out my video on that, which you can see on my channel. Proning still works in some of these patients, so even if they do develop this heavy consolidation, if they respond to proning, keep proning them. It's good for their lungs and may reduce their driving pressures and may improve their compliance. Now, there's a lot of research coming out about secondary bacterial infections, but also fungal infections, especially in the Italian literature. So beware that these patients who may start off with the L-phenotype then develop consolidation. Yes, it may be that they've progressed into an H-phenotype. However, the other option is that they've actually got a secondary bacterial or fungal infection. Now, when we go through the tips and anecdotes video of COVID, we talk a little bit about procalcitonin. I think it's quite a useful thing to have. It's got a very good negative predictive value. If the procalcitonin levels are low, it's unlikely that the patient has a bacterial infection. I'm not saying it's completely not possible, but it's less likely. But similarly, if you've got a high procalcitonin level, do search for infection, especially bacterial and fungal infections. Although procalcitonin isn't that useful for fungal infections, it's more used for bacterial infections. Bear in mind that these patients can develop lung fibrosis. This could be a function of patients continuously having an inflammatory process as mediated by the COVID-19 virus, or it could be related to the things that we are doing to the patient. Certainly, we know that high fractional inspired concentrations of oxygen are bad for patients and can lead to high oxidative stresses and therefore fibrosis. So this is where having a thorough management of a patient and reducing oxygen level, fractional inspired concentrations as much as possible for patients is probably a good thing, and to be careful at every stage because these patients can remain intubated, ventilated for weeks, if not months. Now, the H-phenotype seem to follow two main ways. Firstly, you get the hyperacute. These are the patients who have lots of consolidation, deteriorate really quickly, and I've certainly seen it in patients who have come in on a couple of litres of oxygen and then within hours being intubated, ventilated on 100% oxygen with consideration of proning. So if you do see these patients, act quickly. It's very difficult to intubate these patients once they've deteriorated to the point of being hypoxic on 15 litres of oxygen. They desaturate very quickly and they de-recruit very quickly. Now, the other phase is the biphasic, and we're seeing a lot of these patients. Often these patients have an acute infection, acute deterioration, usually in an L-phenotype, so their x-rays don't look that bad. They start to get better, and then suddenly they develop a secondary inflammatory state, and that secondary inflammatory state causes consolidation, worsening of their PF ratio, and then they start to require higher oxygen levels, may need proning, and some even need ECMO. And that can lead to a much longer recovery process. So in summary, the H-type can present very acutely or can present in a biphasic way with an acute deterioration, getting better and then suddenly gets worse again. They tend to be more PEEP responsive than the L-phenotype and can be treated more like the ARDS patients or the acute respiratory distress patients. They probably should have drier lungs than the L-phenotype. However, how dry is still up for debate. Proning can still be really helpful, so do trial proning, especially if you're going to high driving pressures above 15 or if you're on a fractional oxygen inspired concentration above 60%. Some of these patients may progress to ECMO, and that in itself has questions about suitability, which we will go through in future videos. And the final thing to say is that every step of the way for these patients, think about lung protection. We do not want to cause increased iatrogenic damage to these lungs because they're often going to be fragile, and these patients will often require long periods of time on a ventilator, on intensive care, and then afterwards rehabilitation. I hope this has been useful in just highlighting the difference between the L and the H phenotypes. I'll be going through some of the tips and tricks that have been picked up over the course of this COVID pandemic in the ITU management of these patients, and then we'll talk a little bit more about the specifics of particular patients next.